Hi, how are you doing? So today I want to discuss about the pituitary adenomas, one of the most common pituitary adenomas from both function, including both functioning and non-functioning. That is a prolactinoma, which is a prolactin secreting type of pituitary adenoma. So today we will see briefly about this pituitary, I mean prolactinoma, which is a pituitary adenoma, which is a prolactin secreting type. So these pituitary adenomas are benign neoplasms. Usually they are benign. More than 99% of cases are benign. Benign neoplasms that arise from one of the five anterior pituitary cell types. So we all know that there are different cell types in the anterior pituitary, including that of the uh, somatotrope and the gonadotrope, the corticotrope, and the thyrotrope. So, and the other is the lactotrope, the ones which will produce prolactin. So, which this pituitary adenoma account for about 15% of all intracranial neoplasms and have a population prevalence of about 80 per 100,000, and it is up to 4 per 100,000 incidents per year, which is shown in different studies from UK and other countries. So this pituitary adenomas lack usually this class. They don't have classic oncogene mutations, and usually, and most of them are sporadic. And adenomas, these pituitary adenomas classified by size as macro or micro, depending on their size. Those greater than 1 centimeter, we call them macro, and those less than 1 centimeter, we call them micro. And the other is based on the cell of origin, as we say, whether it is which produce the prolactin, as you say, the lacto cell origin, and the other is gonadotrope, those adenomas with a gonadotrope cells, or with somatotrope, or a corticotrope, or as well as a thyrotrope cell, or a mixture of these cell types, or absence of any cell type may be there in the pituitary adenoma. And the other is based on functionality, whether we classify them whether they are endocrine active or endocrine inactive, or functional or non-functional, whether they produce hormone or not. Based on that, we can classify them as functional or non-functional. So if you say this about if we say this about the pituitary adenoma in general, we just go to prolactinoma, which is the most common one from these pituitary adenomas, including both functional and non-functional. So these prolactinomas are the ones which arise from lactotrophs and account for about half of all functioning pituitary adenomas. And the population prevalence reaches up to 44 per 100,000. And the female to male ratio is for microprolactinomas is usually significantly high for female, while in case of macro is almost equivalent. So this stable prolactin levels in most patients reflect that the growth is slow. Most of the time, the growth of this prolactin producing adenomas are slow. So this is reflected by their stable prolactin levels throughout the follow-up. When it comes to macroprolactinoma, which have a greater propensity to grow and tumor size correlated with the serum prolactin levels, these the ones with large size have a greater propensity to grow. Men tend to present with larger tumors than women, possibly because the features of male hypogonadism are less readily evident. So, when you see the manifestations of this prolactin secreting adenomas or prolactinoma, they are usually attributed to that of the hyperprolactinemia, or the increased level of prolactin, or due to the enlargement of the mass, and the presentation may be this mass symptom like compression symptom in the CNS. So this hyperprolactinemia usually asymptomatic in male, since the high prolactin level is usually associated with symptoms of hypogonadism, and this male hypogonadism may be unremarkable. When it comes to female, this hyperprolactinemia usually, these hypogonadism symptoms are they can manifest early, like with amenorrhea, infertility, and galactorrhea may be there. So in females, usually they can be picked early, as otherwise in males the presentation may be late. That's why that I think male tumors may have usually males have a higher or a larger tumor size by presentation, and that's maybe the reason. When it comes to the pathology and the pathogenesis, more than 99% of prolactinomas are non-malignant, and about half may invade local structures. As we said previously, most of them are non-malignant, and they may invade local structure in up to half of the cases, but invasion of these local structures is not by definition is malignant. So to say malignant in case of this prolactinoma, usually the presence of metastasis is the one which is the requirement. So invasive tumors that doesn't metastasize are usually considered benign, and prolactinomas mostly arise sporadically, usually occur singly, and they are most common pituitary tumors associated with that of multiple endocrine neoplasia type 1. And so these prolactinomas rarely occur in patients with germline AIP or the aryl interacting membrane proteins mutations. In this case, they may occur rarely. So this is a gene mutation, some says, which is in some scientific literatures, which is attributed with the acromegaly of the Goliaths from the from the Bible, the Goliaths which we know in the Bible. So this AIP mutation is the problem of the Goliath and his family. Some literatures says they attribute the problem of the Goliath or the Goliath's gigantism or acromegaly may be associated with AIP mutation, some says. So this mutation also involved in some cases of prolactinoma. This is just not my opinion. I'm just expressing what is said in the scientific literatures. When it comes to the clinical features of this prolactinoma usually come to attention because of symptoms associated with hyperprolactinoma, as we said previously, or with tumor size or invasiveness. So features related to this hyperprolactinoma or the high production of the prolactin are: in women, these symptoms may be primary or secondary amenorrhea, oligomenorrhea, delayed menarche or regular menses with a short luteal phase, infertility, changes in libido, and vaginal dryness are symptoms associated with hyperprolactinemia in females. So these prolactinomas are responsible for up to 30% of cases of secondary amenorrhea. So in case of secondary amenorrhea, it's good as well. Primary is good. One of the consideration or differential is hyperprolactinemia, and the cause for hyperprolactinemia mostly is that of the prolactin secreting pituitary adenoma. In men, sexual dysfunction manifests as loss or decrease in libido, impotence, premature ejaculation, or intracoital erection loss, oligospermia or azoospermia, which is associated with decreased fertility. Now, the other is up to 50% of women and 35% of men with prolactinomas have galactorrhea. So, uh, this galactorrhea is one of the common manifestation of this prolactinoma. The coexistence of galactorrhea and amenorrhea suggests a diagnosis of pituitary adenoma until otherwise proven, and bone density may decrease in both men and women, since this due to the effect of this prolactin on the gonads, which will result in hypogonadism and subsequently leads to decreased in bone density. The other is features related to tumor mass effect. Signs and symptoms caused by large or invasive tumors are often related to compressive effects on visual structures, usually the optic chiasm, and objective findings are superior by temporal defects are the commonest one. By temporal hemanopsia and decreased visual acuity may be there, and headaches are common. Otherwise, seizure and hydrocephalus may be rarely encountered, like seizures may be there in case of metastasis. Otherwise, these are not as such common. So this is a summary of the presentations. And when we come to symptoms associated with tumor mass, they may have visual field abnormalities, blurred vision, or decreased visual acuity. Symptoms of hypopituitarism may be due to the compression of the associated the other structures in the anterior pituitary, which have a different hormonal function. So due to the compression effect on these cells, they may present with hypopituitarism, headaches, cranial nerve palsy, pituitary apoplexy, specifically the cranial nerve series, the commonest one, pituitary apoplexy, which is a bleeding in the tumor. So the pituitary apoplexy may be the presentation, seizures, usually if the temporal lobe is involved by metastasis, and the other hydrocephalus and unilateral exophthalmos may be rarely there. When you see the symptoms associated with hyperprolactinemia, the one is amenorrhea, oligomenorrhea, infertility, decreased libido, impotence, and premature. So sorry for the interruption. So features such as here is a summary as we said previously that the features associated with hyperprolactinemia are amenorrhea, oligomenorrhea, infertility, decreased libido, impotence, and premature ejaculation, oligospermia, galactorrhea, or osteoporosis.